Hi, my name is Dr. Fox, licensed psychologist in the state of Texas, an expert in the area of personality disorders. And in this video, we're going to talk about why BPD tends to get misdiagnosed. And BPD is so often misdiagnosed that you would be surprised, or you may be living that experience, right? And that misdiagnosis can lead to so many severe consequences, not just in the wrong treatment being applied, but the continuance of untreated mental illness can drive greater problems for you and those around you, those that are in your life. So we're going to pull back the curtain, right, as I identify those factors and issues pertaining to why BPD is so misdiagnosed. I think you'll be surprised what you learn, so stick with me. Let's explore it, figure it out, like, share, and subscribe. So let's get into it. So the first one that we're going to talk about is societal and professional stigma. BPD carries with it this stigma, right, that's from society, but even other mental health professionals. And even the word borderline personality disorder, BPD, right, affects how practitioners tolerate the actions, thoughts, and emotional reactions of those individuals. Now, this can also lead to minimizing or overlooking certain strengths that the individual has. So a lot of my clients are along the borderline spectrum. And I think one of the problems is that a lot of folks tend to see what I call, or what has been identified as, the upper 3%, the extreme cases of BPD. Now, the extreme cases are exceptionally rare, but the problem is that 3% tends to get broadened out to the 100%. And that adds to the misdiagnosis, to the ill conclusion. What's interesting is that a lot of mental health medical providers who do run across folks with BPD, if they tend to be moderate, low moderate, they have those traits, perhaps not the full disorder, but traits. More folks are likely to have traits than they are to have the full disorder. And they often miss it because they're only looking for that upper 3%. And that becomes a problem because that can lead to misdiagnosis and things like that we're also going to talk about. And obviously the whole video is about misdiagnosis. But there's other factors as well. So I think that sort of that stigma adds to the misunderstanding of the disorder. It also, a lot of mental health providers and medical providers, when they see borderline personality disorder in someone's chart, or, that they realize that that's the diagnosis, sometimes they get afraid. Sometimes I think that mental health providers, even the ones that I work with, that I train, and my students and things like that, then when we talk about BPD, they have this misunderstood kind of representation in their brain, right? So I remember a long time ago that I had this student, and we talked about, the client that she was going to see. And this client met criteria for BPD. And when I said that, the student said, "Oh no, BPD." And I said, whoa, whoa, whoa. I said, "Where's that coming from?" I said, "Have you worked with someone with BPD before?" Right? And she said no, and I knew she hadn't. And I said, "Where's this coming from?" She said, "Well, I heard they're just, this, that." And I said, "Well, the problem is," and then I explained the data, right? We looked at the data. I explained, that's not realistic. I said, we have to be realistic. And, she had a great experience working with that person. She helped that person a whole lot. And it's those experiences, the reality of those experiences, that help lessen the professional stigma. And I think that it can lessen the societal stigma as well. And I think that we need to be realistic about what BPD is, about what it means, how it's displayed. And that's, of course, a big component of this channel as well, is getting an understanding of mental health issues, particularly BPD and personality disorders. So let's get into the next component as it relates to BPD being misdiagnosed. There is this belief that people under 18 can't have BPD. Now, this is a slippery slope. So make sure you got your galoshes on. Galoshes are more for the rain. Do they help you stop slipping? I'm not sure, but you get what I mean. Now, in the DSM-4 and the DSM-5, it specifically states that a BPD diagnosis could be applied to children and adolescents. This is people under the age of 18, if they meet the symptom picture for at least 1 year. Now, here's the thing, and this is what I tell a lot of my students, and this is also what I tell a lot of mental health providers, right, when I'm doing training with them, is that everyone at some point in their life, right, during their adolescence, okay, that they're likely to display BPD traits. They're likely to possibly, right, meet criteria for BPD. So we got to be really, really careful. And I think the reason why this specific classification, this specific notation is in the DSM, which is the Diagnostic and Statistical Manual. It's in the 5th edition now. I think it's right back there. Oh, wrong side. It's right back there. And the reason why it says this in there is because you have to be so careful. Because there is a big misunderstanding about BPD, obviously, but also you have to be sure that it's evident in that individual. Now, could they have traits? Sure. But again, they should be present for at least 1 year. And over that year period, right, obviously that individual, right, the adolescent, that teen, is going to encounter different circumstances, right? They're going to have different issues. They're going to have breakups. They may be dating. They may not be dating. They may be isolating themselves. They may, they're still discovering who they are. So unstable self-image is not uncommon. Ruptures in relationships is not uncommon. So all of these factors, is certainly critical. Many students, particularly girls, regretfully, in their teens, there's a massive increase of self-harm, non-suicidal self-injury, as well as suicide. So, and not every teen who cuts themselves and hurts themselves and things like that has BPD. That's important to realize as well. So we have to be really clear that over that year, are these symptoms present? How are they present? To what extent? Because in many ways, in many instances, many adolescents, teens are going to exhibit these traits, but they're often going to be very specific and short-lived. There may be a specific crisis that goes on. The parents may be getting separated. There was the end of a relationship, the first end of their first sexual experience, whatever it may be, that can cause them to have these maladaptive reactions. But once that is handled, once that is addressed, then they start to go back to a restabilization. And here's the thing for those early BPD cases, right, those individuals, is that you see that those traits still kick up. Those traits are still present. So that's why you have to be certain that it's over that 1 year period. Okay, and you want to be really, really careful. Okay, particularly with giving a diagnosis to an adolescent or a teenager. The next one is that BPD is a complex disorder, right? BPD looks like so many other mental health conditions, and it co-occurs with so many as well. For example, research has shown that bipolar disorder and BPD are comorbid in approximately 27.6% of cases. That's a lot of overlap, right? That's just over a quarter of the cases. Depression is also very confusing because individuals that are on the BPD spectrum or people that have BPD, that they're going to have depressive episodes. But you have to be able to rule that out from the depression. Just those depressive episodes don't equal major depressive episode. So you have to be able to rule it out. That's why it's so important that you're working with someone who knows what they're doing, who's working with someone who knows what they're looking for, okay? Because it can easily be misunderstood. And people can have an agitated depression, which is a lot of restlessness, a lot of irritation, a lot of ill responses, and that could be misconstrued as BPD in some cases, or could be major depressive disorder with anxious distress and with BPD traits. So also teasing that out. ADHD is another component that is often confused with BPD. So that's important. That has to be ruled out as well. Where's that hyperactivity? Where's that inattention coming from? Okay, is it a factor of emotional components or is it a factor of environmental response? Is it that individual and how they function across many different environments? That's ADHD. There's also complex post-traumatic stress disorder and PTSD that is not complex PTSD as well. So it's about teasing those out as well. So, and then there's also psychosis, the individuals that are at the probably high or severe or extreme level of BPD are at a greater likelihood to have psychotic breaks. Okay? Does that mean that they're schizophrenic? No. Does it mean that it could even equal a brief psychotic episode? No. So you have to be aware of that. So you have to be able to tease that out. And the way that I look at this is that knowing that it's a complex disorder, my next book that is going to come out either later this year or early next is going to talk about this complex borderline personality disorder. And it's going to talk about those co-occurring conditions, right? And how they manifest and how you can help to identify it and how you can find a mental health provider that can help you. So I'm going to, one of my future endeavors is going to help folks better identify those co-occurring conditions that come along with BPD. So I think if we can lessen the complexity, you can have greater understanding of it. And that's so, so important. The next component is the myth that BPD is not treatable. That is an old fallacy. That is 1970 data. I was born in the 70s, so great decade, but bad decade for BPD because it's old information, right? There are a variety of what are called empirically validated treatments. That means that research supports these treatment approaches, and there's a number of them. I'm going to tell you some right now. There's dialectical behavior therapy. There's mentalization-based treatment. There's schema-focused therapy. There's transference-focused psychotherapy. There's systems training for emotional predictability solving and problem solving. And there's even general psychiatric management. So all of these have been found to be effective treatment methods in treating, lessening BPD. Right? And if you've watched my other videos, you know that individuals with BPD also encounter remissions, and that those remissions can last for 2 years or more. So you want to learn those skills. You want to learn to manage that core content, right, which I talk about in other videos as well. And if you can get a handle on it and you can manage it and you can lessen it, that helps you. But it is a treatable disorder. So that's another issue that leads to that misdiagnosis and confusion. The next component that we're talking about is gender confusion over BPD. This is pretty prominent. This is prominent in society. This is prominent certainly in the professional community as well. And the belief is that approximately 75% of those diagnosed with BPD are female. The reality is it's more like 50-50, okay? But let me explain it, okay? So there is approximately 75% of females that are diagnosed with BPD in clinical samples. Now, there's more equal male to female ratio in community samples. So what that means is in patient settings, there is a higher likelihood to diagnose females with BPD. So out in the community, it's equal to male-female. So it's about 50, about 48, 52 is more the consistent data. That's pretty specific. But you get what I mean, right? So is some of that misunderstanding, right, where they're saying that it is clinical samples, those that are inpatient, is that a component of misdiagnosis? Well, women with BPD are more likely to have co-occurring diagnoses of PTSD and eating disorders, while men are more likely to have co-occurring diagnosis of substance use disorder, as well as schizotypal, narcissistic, and antisocial personality disorder. Now, this can be explained as gender differences in BPD may be a function of impulsivity. Okay? Now, this may be in that men and women may differ in the specific type of disorder of impulse that they predominantly display. For example, women are more likely to use food, like internalizing behaviors, and men, alcohol or drugs, and acting out against others. This is externalizing behaviors in a self-destructive manner. And what happens is that this adds to that confusion. So you've got two different classes, so to speak, right? You have males, females, and the way that they exhibit these traits is different. And what I've encountered, over the years is that you can have a female with antisocial personality disorder is often misdiagnosed with BPD. You can have a male with BPD who's exhibiting those symptoms misdiagnosed with antisocial personality disorder. So that confusion, of course, leads to a misdiagnosis, and they are vastly different. Okay, it is so important to know that. And I've heard it said, and it is massively inaccurate, that BPD is the female form of antisocial personality disorder. That is absolutely positively not true. There is no data to support that at all. There are some folks who do overlap in both, but you cannot make that gender distinction. So please be cautious. Don't believe that stuff, because that adds to the misdiagnosis and misunderstanding of BPD, which this channel is about having greater understanding about BPD, what it means, and those traits that's exhibited. And this video in specific about helping you identify the diagnosis. You can talk to your medical and mental health provider. The next one is that people choose to behave in a particular way that are or includes BPD traits, that BPD is a choice. People with BPD would never choose to feel like they do. The intensity of those negative feelings of self, others, and their world is so vast. I have never had a client say that they choose to think, feel, and act the way they do along the borderline spectrum, who have this intense abandonment, emptiness, difficulty controlling their responses, right? Difficulty seeing the world in a more accurate way. I've never had a client that's volitionally said that, right? Imagine that you grew up in an emotionally deprived environment with little options to respond, feel good about yourself, or see a different way of living. The power of volition doesn't get instilled in you when you're growing up in this environment. But torment, fear, impulsivity, and self-contempt blossom, and they intensify over the years, which breeds an increased likelihood of falling into the category of BPD or developing BPD traits, right? BPD can also be seen as a maladaptive response to manage internal and external stressors, right? And inconsistencies in the world. It's very, very difficult, very, very painful disorder to try to manage and work with, but we know that it is treatable. A research study found that the label of BPD was enough to change the behavior of treatment providers, right? These researchers compared nurses' responses to hypothetical patients with BPD and schizophrenia. What they found is that a significant proportion of nurses were more likely to remain sympathetic towards patients with schizophrenia and made belittling or contradicting responses to statements made by patients with BPD. It's likely that the nurse's perceptions of the underlying motives of the patients, this is implying self-control, influence their responses. People with BPD are seen as making a choice to act that way. I'm not saying that you shouldn't be held responsible for your behavior. I think we all absolutely should, and I understand that. But what I'm saying is that I think many times people with BPD, they're like, oh, well, they're doing this for this reason, and this is like it's planned out, that it's expected. And that just isn't true. That it is a maladaptive response to stressors, right? So when people encounter a lot of stress outside of BPD, right, a lot of them drink alcohol, right? So are they doing that because they want to purposely just destroy everything? Are they doing that because they purposely wanted to? No. What they're trying to do is they are externally trying to manage their internal stress in a maladaptive way. Well, choose, right, how you see people. Do you see them as angels? Do you see them as devils? Do you see them as heroes? Do you see them as zeros? Are relationships hard to maintain? Are you afraid of being left alone? Are you afraid of being empty on the inside? All of these different components. And people don't make a choice to feel that way. So it's so important that people realize that. Now, I think that we can lessen the misdiagnosis rate of BPD. We have to learn about it. We have to confront these issues, right, that we just discussed. If you're wondering if you have BPD, find a trained mental health provider that can help you. Diagnosis is for treatment, not for self-definition, right? And it's so important to identify the diagnosis so you can plan out a treatment course. And by doing so, that can help you move mountains. It can help you change your life, do things differently. And that's the purpose of diagnosis, to work and identify treatment, not to identify the individual. So I hope that you found this helpful. Please like, share, and subscribe. And thank you very much for your time and attention. And take care. Bye-bye.